what is the problem we're trying to solve in healthcare, or should be trying to solve, in your opinion? And do we have agreement on that in this country? Kind of a rhetorical question, but I'll ask for a volunteer.
So the Affordable Care Act, those of us who supported it and tried to implement it always said that it both would reduce costs and improve quality. And the theory was that when you get everybody into the system, costs would go down. That was criticized. I mean, I think the conventional wisdom is that the Affordable Care Act did not do too much to reduce costs. I always believed that if the insurance system were reformed, what I believe correctly, in my view, that is, if the insurance system were reformed in a way that insurance companies were forced to compete on price, they would have no other alternative but to drive costs down, but to get really tough with the providers, because if they didn't, they just wouldn't be able to make a go of it. So the answer, sorry, this is a long-winded way of answering your question, Sarah, but I don't know that we do agree on the goals. I always viewed reducing costs as the most important thing. I mean, you can argue about whether the United States, the quality of health care is as high as it should be, but I don't think that's a big problem. I just think the cost is the big problem. I don't know whether it's 17 or 18% of the GNP now, but you just can't have a system which accounts for that much of the country's wealth. So my answer, if I've got to rank what the problem is, what the problems are, my number one problem is cost.
Thank you.
So somebody who supported the Affordable Care Act, and on the ground, interesting, you're right, I don't think we have an agreement, because on the ground, the problem that we were trying to solve for was apparently access, right? And so thinking about who actually has access to health. But I think the question also was, what kind of access? And so I think that was actually something, like, it's not just access. Just because you have access to health care doesn't necessarily mean you're going to get health care. And, you know, on the ground, it's a really big, interesting aspect. And then what kind of access? Are you needing in health access to social services? Are you needing access to housing? Are you needing access to food? And all of those things are attached to health. And I think I read somewhere about how comparing the United States to, like, say, the English system or France system, and if you actually looked at their costs of healthcare, it was actually really low. But if you added in their social services, it actually was comparable to the United States. And why that's really important is because the shift of that cost piece was actually, you know, is all of a sudden, it's like it's an equal proprietary. But in the United States, we think about cost based off of a hospitalization, or the cost of how many days they're staying in a hospital, in the bed, and it's a medical issue when really it's actually not. So I think you're right. The question is, are we all in agreement to what that question is, of what's the problem we're trying to solve? From the ground, we fought for access,
So I would start with, do we even understand the ecosystem before we really define what we're trying to solve, right? So compared to where you come from the different ends of the spectrum, what role you play, what you're trying to solve actually differs, and what means to you in the role that you're playing in that healthcare ecosystem. As you said, you hit on access, Jay talked about costs, someone is going to talk about affordability, someone is going to talk about competition, someone is going to talk about choice, someone is going to talk about reimbursements. Unless we understand the ecosystem of how it works and what it means to the different people who fall into the different segments and how everything gets connected together, defining what we're trying to solve for is like a wide range of spectrum, and I think that's what we did. We helped build the Rhode Island State Exchange, We tried to hit on those 3 or 4 parameters, which really requires the connection of connecting just not the policy or just not the offerings from an insurance plan standpoint, but also looking at consumer experience and enabling them to make a choice. And we tried all different 4 or 5 parameters. And in all fairness, since it's a small state, it's an easy thing to, I shouldn't say easy, she's gonna say no, but it's a small, I'll still say it's a small state to really, sorry, I come from Massachusetts, I get to say that. But you can try out different ways of connecting the 4 or 5 pieces, but again, does everyone in the different areas of what they belong to, whether it's politics or the system itself, do we really have clarity on what it looks like and what we're trying to solve? And only once you get there is when you can clearly define or actually define a path that can help solve these 4 or 5 big hits of cost, access, affordability over that.
The answer is no. We're unlikely to have it in the near future. And so therefore, we have to take an approach that takes that into account.
There was mention of cost, competition, access, affordability, choice, but no one said better health. And I guess, Jay, maybe when you talk about quality, you know, there's a little bit of that, you know, I think quality is, I think there's a lot of people out there who believe in, I call her like the magical quality fairy that like just kind of sprinkles quality all over our healthcare system, but people aren't kind of focus on like what that really means. And so anyways, quality health outcomes, I would maybe perhaps add to the list of problems we could try to solve. So let me get to this this question of the Affordable Care Act, because obviously all of you were involved in implementing it in one way or another. And so talk to me about what was unique about the Affordable Care Act in terms of the role of government versus the role of the private sector, or if there was something unique. Was it in some ways kind of an attempt to create like a different business model for health insurance, in which the government was not only setting up a market but also selling the products on that market? And yes or no? What did we learn from that experience of that intersection of public and private?
I want to hear your answer first, and then I'll do mine.
Okay. Yeah, and I'll try to be less long-winded. Well, what we learned is, for better or worse, the government, or anyway, the Obama administration, fortunes were tied in with those of the insurance companies because of the way it was structured. The administration had a stake in the success of the insurance industry, and I mean, you can argue that's good, but in a lot of ways it's bad. The government's no longer completely neutral with respect to the industry, and not really an enforcer with respect to the industry. They're a partner. And at HHS, we love to talk about partners, but I'm not so sure it's such a good thing to be partners with the industry. Anyway, for better or worse, that's the system we came up with. One in which the private carriers are, it's not, the government's not in the insurance business, the private carriers are, but the government is in the business of trying to get the private carriers to succeed.
There you go.
In Rhode Island, the way that we implemented that, the bill was around the concept of a business in government. And I will tell you, it was excruciatingly difficult to do it. We had an investor. The investor was the federal government. From my perspective, we owed the investor a return, right? And the return could come in a variety of different ways. One is lower cost, better quality, more competition, more entities in the market, and hopefully over time, money back. But the concept of that, of trying to do a business, and this is the thing I've tried to wrap my head around in the conference that we've had, and why when I said yes, I would do this, I came to the whole thing so that I could understand what the message was, right? So in this case, it was a business trying to do a startup in a government setting without any clarity on virtually anything. Structure, money flow, accountability, all of those things. And the barriers and the difficulty in doing that is significant. Now, what Eric is talking about here, I think is almost the flip side, I think, of business being started and then inculcated or used or substituting for a function. And this would have been a great opportunity to experiment with 5 or 6 or 10 different models across the country. But the problem was, from the administration's perspective, we passed a bill that couldn't be fixed because of the politics. And so the implementation of it had to be done from a very delicate perspective politically. And so that range of experiments at the state level with different models never happened. And in fact, what we ended up with only 13, or I can't remember how many, 13 state exchanges, which nobody imagined that would be the case, right? I mean, you didn't imagine that at the beginning, did
Yes.
you?
Yeah, I mean.
Did you think 13?
I thought it would be about a third. Yeah, this is a sidelight. No, but at HHS, everybody was always telling each other, oh, the states are going to enact their own. And they never did. And one of the mistakes we made is we never planned from the beginning to have a federal exchange throughout the country. And if a state happens to do it, fine. But we were cheerleaders for the states, but the states didn't want to be cheered for.
Right, no, and it wasn't that the states didn't want to be cheered for, it was that the politics of the governors overcame what would have otherwise happened. And I think that fundamentally changed the dynamic of the whole thing. And that's gotten us to the point that we're at today. It has nothing to do with what's happening on the ground. It has nothing to do with access. It has nothing to do with reality. It is a political fiction that we're debating over. And the ability to understand the landscape on anybody's part it's almost like you can't even have a conversation. It is an insane situation.
Yeah, so to your question, right, which was what was the attempt of the ACA and what was the attempt? So yes, this right here, right, forgot the piece of what the attempt of the ACA was, which is a humanistic piece to that, right? So here's the thing, is that the way I looked at the attempt of the ACA was to have what I really believe was the philosophy of the ACA, which is what we actually, so I'm part of an organization also called Doctors for America, and one of the things that we actually really pushed for was the humanistic piece to this, right? The ACA allowed for the push of being able to make sure that people who had pre-existing conditions would no longer be faulted for having pre-existing conditions, right? Pregnant women would not be looked at as a pre-existing condition, or having an allergy wouldn't be that way. I mean, we use talking points based off of that attempt, to me, was in the good of that administration to actually put forth. I do think that it's really important that there is a relationship and a partnership between insurance companies and the government. And the reason is because the delivery of our care in this country is the insurance companies. Whether some of us like it or not, it doesn't matter. The point is that is the actual delivery. That's the everyday life of everyday person. All of us on this panel and everybody that I take care of, you know, I mean, it's just everybody in this room, right? And so that relationship is super important, and they have to play in the same sandbox. And the reason is because that's our reality. And so the attempt of the ACA, and I think for the administration or just us on the ground wanting the ACA to pass and wanting the ACA to be a part of this was to be able to say, hold a little accountability in the same sandbox. So whether there's an accountability in the government, whether there's accountability in the insurance company, that partnership needed that accountability. And there was. It actually helped us start that conversation and actually implement that conversation. Whether it was good or not good, it actually did help.
And thank you. I think it's also just kind of worth pointing out that this model of, you know, the government like financing and setting some of the rules and the private sector implementing wasn't new with ACA. It was just maybe a little newer with individual market. I mean, you have in Medicare, you have Medicare Advantage plans, and there was back in the, I don't know, was it the 80s or 90s when Medicare Plus Choice kind of started, where there was like an
And there's Medicaid managed
and
care.
then there's Medicaid managed care, which is probably like the vast majority of care delivered to at least, you know, the healthy, you know, moms and babies population, and increasingly to the more complex needs populations within the Medicaid program is all being done through private companies. So this interplay is critical. Dharma.
It's always easy to look back 3 or 4 years and dissect what was right and what was wrong. But according to me, there was a huge, if I use private terms, there was a venture capitalist investment which was significant. Did the blueprint for building out the house was complete before they started construction? The answer is no. So if you left the 20 or 30% blueprint not mapped out the right way, then it translated to everyone's interpretation on what that could be and what that could entail. And it depends on every state that we picked up. And to Jay's point, I don't think federal exchange was even part of the roadmap at the first place. Now, if you put the politics into the equation, and if everyone is not picking up, and you really want this to work, now you have to find, I call it the turnaround solution that can still provide the same. And then the focus shifts to how do we help enable do that. Meanwhile, you got the 13 or 14 states who are actually looking at none of these states where, if you really understand the way their infrastructure or the systems work, most of them have been mostly outdated, according to me, at least 20, 30 years. Everyone did a revamp of their whole or part of their infrastructure, leveraging the same venture capitalist investment on the umbrella called ACA. And we extended that, to answer your question on the public and private mix. The key of the equation was, yes, you can integrate or bring a private sector mix into the equation. We did run the Rhode Island one more like a product company in that particular group. And trust me when I tell you, I've done all the Excel spreadsheets on return on investment of what investment is coming in from the federal government and how do we generate revenue by year 2 and year 3 so that it's operationally sustainable. Because in this state, the way the politics happened, you're just part of a state agency. You're really not getting the green path to either become a nonprofit or et cetera, et cetera. We couldn't set it up. And they don't want to allocate budget to fund this anymore. That politics was going on as well. So we had to come up with ways as to how can this generate money by itself without taxing the end consumers from an insurance plan standpoint. How can we leverage the investment that we had and the infrastructure that we created and the tools that we built, and how can we relicense them and how can we resell to really generate revenue so that it can be operationally sustainable. Now, that in state government, unless it's very rare, I haven't seen that. I don't know whether it happens to the federal government or not, but there is a way to meld it, and you can combine those pieces and do it. But can you put stop breakers, and did you get the right set of people convinced? And this was the same conversation from yesterday, where we're saying, unless you can explain what you're doing in a value proposition to what it means to me, if I may say so, me, from the viewpoint and the ecosystem that I come from, I'm not going to listen to how much hour you're going to tell me, right? So there is a way to meld it. Now, too many good brains can even actually do it better, but that's more of a pilot, and again, she's going to kick me because I say it's a small state. I kept saying that if this was done by 3 or 4 states at the same time, that's probably a model that can be expanded and replicated across both state and federal lines.
I work in the spectrum of capitation. And, and what I love about that is because it gives us the freedom to come up with innovations of what it is that we can do through the lens of the person that we're taking care of.
So in other words, rather than say the payer, whether that be Medicare or an insurance company, saying, okay, like we're going to pay you, the doctor, for this menu of things, and you can do this menu of things, but not that thing.
Right.
Instead of that fee for service, capitation is like, all right, you're going to get basically a set payment to take care of this person.
Right.
And do what you got to do.
Right.
Right.
Do what you got to do to decrease the cost of that person going to hospital. So I'll give a great example. I was just talking to a table of folks, where I had a patient who really literally, she had what we call postpartum psychosis. That's the medical issue, right? The medical issue was that she had a baby, she had a psychotic episode post her baby, she had all of her children taken away from her. And she got labeled paranoid schizophrenic, which means that she's got labeled that she has a mental disease for the rest of her life, but she's never had this before, never was in a hospital. And the thing was, now she's going to a hospital all the time because what she was really distraught by wasn't this postpartum psychosis, the medical disease, right? She was distraught by the fact that her children were taken away from her, right? So the thing is, in capitation, as a doc, when I see her, she was this destroyed young woman. Every month she's going to the hospital. My charge is how to get her to not go to a hospital. So that's the money side, if you will, right? So my charge is to not get her to go to hospital, and I find out that the one thing that's stopping her from going to the hospital, like she has to show up at court to get her children back. And the thing is, the state says you need a psychiatric evaluation. That's the one thing that you're going to be able to get, like you need to determine if you get your children back, which will stop her from going to the hospital if she got her children back. Okay, so the thing is, the state doesn't provide this mandate. They don't provide the service to get her the evaluation to that mandate that was given upon her. She's poor. She doesn't know how to navigate the system. She can't have the conversation about the politics, right? She's not. And she's going to a hospital all the time. And my charge again is to decrease her hospitalizations. The one thing that stopped her was to get her children back, to go to court, was to get this evaluation. So in capitation, I was able to say to my company, hey, man, let's invest $300 to actually get her this evaluation to see if she can get her children back, see if she's competent to, right? And fee for service, I would have never been able to do that. In complex case management and capitation, I was able to actually do that. My company is so pro in thinking about, because at the end, if you really want to talk about the return of investment here, is that the $300 of upstream investment saved them thousands of dollars on the downstream because I provided a psychiatric evaluation for her. She got her kids back, never showed up in the hospital again. And she sees me. Now, one could argue that that's not a medical issue. Actually, I would argue that's a hugely medical issue. The lens of how I actually are able to take care of her medical issue was through the lens of a legal service, right? That's a medical issue. That's a health issue. So when you talk about better outcomes of health, right, we skirted around that. What is health? How are we defining health? We're not defining the health as just the absence of disease. We're defining health as where people work, live, and play and pray. That's health, right? The factor that I could talk about obesity all day long for kids who are obese, but they don't have a safe neighborhood to play in. They don't have green space to play in. So they got concrete jungle. That's their jungle. So the thing is that to me, the health investment is actually creating a park. Take away the crime, right? That to me is a health issue. So if we don't look at health in all policy, and if we don't think about the fact that every single thing that we do is a health issue, and politics doesn't think about it that way, and we keep running in our silos, and the government doesn't think it that way, and the private sector, public sector doesn't think it that way, then we're not going to be able to solve the problem. And to be honest with you, I think there's a bunch of solutions on the table. We just don't have this all the time. And you don't, and my patient, that 27-year-old's voice gets lost in the sauce.